Can you tell them to give the countdown for starting recording?
Yes, ma'am.
Yes, ma'am. It is started already.
It started. All right.
So we welcome you, ma'am, on this masterclass for this very pertinent topic, which constitutes a large chunk of our infertility patients. So we are all eager to listen to you, ma'am. Over to you.
Thank you, Bhavani. And thank you, Mr. Sharma, for having me over to speak on this topic. This is really a very sort of a topic which eludes us a lot. And if we say that of all couples experiencing infertility, almost 30% are diagnosed with unexplained infertility after standard evaluation. Yeah, if we go deep into evaluation, we might have a lesser percentage which would belong to unexplained infertility, but just standard evaluation, 30% straight would go into unexplained infertility. Evaluation includes demonstration of at least one patent fallopian tube, documentation of ovulation of the female partner, and a normal semen analysis. If these three things are present, we say this is possibly unexplained infertility if we do not find anything else. In clinical practice, however, we recognize the limitations of this diagnostic evaluation. What are the contributing factors? Well, I wouldn't say these are the contributing factors, even though the books feel that all these should be contributing factors. Advanced age, even though everything is normal, pregnancy doesn't happen fast. Same is with low ovarian reserve, poor egg quality. And how do we know egg quality? There is no way of knowing egg quality till we have seen a oocyte in vitro and we have given the chance to fertilize it. Then minimal, mild endometriosis. There could be uterine factors, cervical factors, very beautifully patent tubes, but dysfunction of the tubes, immunological factors, genetic factors, fertilization defects, and lifestyle factors. So all these could lead to everything looking normal, but still a pregnancy is not happening. And this is the most common question I face from my patients who come to me, that everything is normal. We have been trying, going to doctors, but nothing is happening. Why is it so? Because when we see one patent tube, when we see a normal looking uterus and endometrial cavity, and when we see that ovulation has happened on one side, and on the other side, we see a normal semen analysis and normal sexual contact history, what do we not see is all this here. We do not see whether the egg has been picked up by the tube. We do not see if the sperm has reached the egg and has been able to fertilize it. And then after fertilization, formation of a 2-cell embryo, a 4-cell embryo, 8-cell, 16-cell, 32, 64-cell, a morula, and then a blastocyst, and then at last the implantation. All this is absolutely unseen. And hence, even a patent tube with proper ovulation and sperms reaching the genital tract of the woman, yet pregnancy does not happen. So there is no male factor, there is no uterine factor, there's no tubal factor, and there's no ovulatory factor, and there is no peritoneal factor. And yet pregnancy may not happen because all this, what you see here, what is happening in the tube from the fimbrial end, ampulla, and to the cornual end and into the uterine cavity, we are blinded towards it. In IVF, we can see a lot, but then again, the implantation process where we roll a good embryo into the cavity remains unseen. What is the role of laparoscopy in unexplained infertility? Well, in the absence of evidence of tubal or other pelvic pathology, on initial less invasive investigations. What are the less invasive investigations? Basic is a pelvic ultrasound, a per speculum per vaginum, a vaginal examination, and if all that is normal, we proceed for a HSG, hysterosalpingography. So this is evidence of no tubal or pelvic pathology on examination, ultrasound, and X-ray. Laparoscopy is not warranted in the diagnostic workup of infertility nor is it needed to diagnose unexplained infertility. We have to remember this. Laparoscopy is not a part of diagnosis unless we find a pathology and we put in a laparoscope to verify the diagnosis and correct it. Laparoscopy with direct visualization of pelvic reproductive anatomy is the only method available for specific diagnosis of peritoneal factors that may impair fertility. There may be a place for diagnostic laparoscopy in young women with long periods, means over 3 years of infertility, but no recognized abnormalities, especially in cases where other treatment modalities have not been successful. And the only thing is the impact of minimal and mild endometriosis on fertility is very, very small. So if we are putting in a laparoscope only to see minimal and mild endometriosis and treat it, it may be not be cost effective or procedure effective also. And most women with significant adnexal adhesions have historical risk factors, means they will have a history of some surgery done before, or a tubal factor, ovarian factor in the past, which could tell us that, oh, maybe there are a lot of adhesions over there. Myomectomy done in the past, we always think of it, there could be adhesions which make a patent tube also non-functional. So this was the opinion of ASRM committee opinion in 2015. What is the management of unexplained infertility? Since there is no treatable cause, since no treatable cause is identified in the setting of unexplained infertility, treatment is by necessity only empirical. So we only give empirical treatment once we make the diagnosis of unexplained infertility. And what is the management like? Well, it is first management is expectant management. If the woman is ovulating or she's made to ovulate, give them time to conceive. If they are having normal sexual intercourse, the semen is normal and the tubes are patent. Next, if that has not worked, we shift over to ovarian stimulation with oral medication or injectable gonadotropins with intrauterine insemination. We'll talk about this. And the last is for unexplained infertility, treatment is IVF. So having said that, I will come to expectant management first. Now, expectant management has long been an option in the management of unexplained infertility. In fact, couples who are labeled as unexplained infertility wait the longest to reach some type of treatment strategy which is outlined for unexplained infertility. When they feel everything is normal, they want some medicines to help them, or they just want more time so that they could get pregnant. However, the Canadian Fertility and Andrology Society 2019 said that in couples with a good prognosis, expectant management can be offered. And this was very good evidence. Now, what does it mean in couples with a good prognosis? How do you know which couples have a good prognosis, where you should wait? Just give expectant management, means explain the fertile period, identify the fertile period, let them have natural intercourse, and wait and watch and see that a pregnancy might happen. You do not really treat them with medicines. You only let them have sexual contacts more often, more frequently, and more during the ovulation period. So which are the couples of good prognosis? Well, there has to be some way to say that, okay, this group is good prognosis, this is medium prognosis, and this is poor prognosis. So we should not wait for this patient, or we should wait a little bit, or we should wait a lot. So there have been prediction models. Henols was the first prediction model, which was produced in Human Reproduction 2004. And it's very interesting that this model has 5 predictors. Female age, you can see on the chart here, duration of subfertility, whether female subfertility is primary or secondary, and sperm motility, and the last is referral status, whether this case has come from somebody referred to you or it has come directly to you. So all this give it points. And if the score is over 30, I mean, the prediction says if the score is, the higher the score is, the lower is the chance of getting pregnant. So if your score comes to a place where you say that you see this prediction model, So where you say that the chances of getting pregnant is less than 30%. That means this patient, this couple is of, it has a poor prognosis of getting pregnant on expectant management. But if the chances, if the score, the higher the score, the lower is the chance. So the chance goes lower and lower as the score goes higher and higher. So as the score goes higher, the chances of pregnancy becomes 3, 5, 13, and the average is around 30%, which we take. If the chance is less than 30%, then we say very poor prognosis for getting pregnant on expectant management. If it is more than 30%, we say, okay, we can wait a little more for this patient. However, this did not look very complete in 2004, and we thought many more factors were important, and therefore came a revised prediction model for natural conception, which was given forth on RBM online by Benstrop et al. In 2017. Here, the higher the score is, you have better chance of getting pregnant. And they've taken so many factors in addition to what was taken in Henol's prediction model. So what are the extra prediction factors? Is selected additional 7 factors. One was body mass index, the cycle length, basal FSH levels, because when this prediction model was made, till then AMH, in the first prediction model, there was no AMH. Then tubal status, history of previous pregnancies in the current relationship, and which means ongoing pregnancy after natural conception, fertility treatment, or miscarriages, anything which happened. Semen volume and semen morphology was also included in this. And if you can see, all that has come here. And higher the score is, if the score is points is 120, 71% is the chance of a woman to get pregnant. If we take it to around 30%, then 100 points, if we score on this scoring board, then the chance of getting pregnant is about 29%. So this is how it differs from Henol's prediction model. And these prediction models help us to identify which couples might get pregnant easily. Now, if you see here, then the highest number is woman's age. The lower the age, the higher the scoring point she gets. 20 gets 18, 24 gets 16, and 40 gets 2, and 42 gets 0 points. Duration of subfertility, if it's only 1 year, 30 points. If it is 8 years, 0 points. Third line referral, if she's come through referral, she gets, if she's come directly, 9 points. If she's come through referral, been to other practitioners, nothing. FSH levels, the higher the levels go, the scoring becomes lower and lower. Same way, BMI, the higher it is, the score is low. And then you come to semen volume, semen concentration, morphology, and tubal pathology. So the score, the higher the score, the better is her chance of getting pregnant. A young woman whose duration of subfertility is only 1 to 2 or 3 years, her FSH levels are low, cycle length is okay, BMI is not too high. All these factors will contribute to a good prognosis couple. So having said that, we would have to wait for, generally expectant management is given for 2 years, sometimes even 3 years, depending on the patient's profile and their eagerness to get pregnant. The second line of treatment is ovarian stimulation with IUI. Now, ovarian stimulation refers to pharmacological treatment with the intent of inducing development of multiple mature ovarian follicles, and is a preferred term previously described as we used to call this super ovulation, ovarian hyperstimulation, controlled ovarian hyperstimulation. All we need to say is ovarian stimulation is required with IUI if we are treating unexplained infertility. It should be distinguished from ovulation induction, which refers to the pharmacological treatment to the anovulatory woman to induce ovulation. So even if a woman is ovulating, we need to do ovarian stimulation. Ovarian stimulation with IUI is believed to improve cycle fecundity by increasing the number of oocytes that are available for fertilization, while increasing the number of motile sperms in the uterus through IUI at the time of ovulation. In short, it increases the gamete concentration in a given cycle at a given time Gamete means oocytes as well as sperms at the time of ovulation to lead to a higher chance of pregnancy. Now let us see what has happened in the world literature. It was said that IUI is the second line treatment. However, in UK 2013 NICE guidelines said that intrauterine insemination with or without ovarian stimulation should not be routinely offered to couples with unexplained infertility, and that IVF would be considered after 2 years of expectant management. So they said just give 2 years of expectant management, tell them the fertile period, let them have more sexual contacts. But they said that no, we do not allow IUI, and they stopped the funding of IUI. This was the worst thing they did. But then in 2015 survey of UK fertility clinics, again, when a survey was done, it was found that 96% are still continuing to offer IUI. Now, because the funding was stopped, and we all know that NHS runs all the patients, I mean, maximum number of patients are treated through NHS through the national funding. So if the funding stops, then IUI stops ideally. So anyone who went through IUI had to self-fund it. But then there was a lot of antagonism, and this antagonism came up by two important persons, Professor Roy Homburg and Dr. Ghulam Bahadur. And they published a nice update guidance on IUI rejected by professional. I mean, there was a lot of uproar that we cannot let these nice guidelines operate. The world has to open their eyes. And they said first-line fertility treatment strategies regarding IUI and IVF require clinical evidence. And they said the evidence of financial, economic, and clinical considerations presented within this commentary strongly favors IUI as the first-line treatment option for subfertility, especially for unexplained infertility. And national funding strategies should include IUI for most first-line treatment options. And the UK NICE guidelines need a radical review of IUI procedures. Having said that, the annual meeting of ESHRI in Geneva in 2017 happened, and in that two landmark papers were presented. One was by Cindy Farquhar, who's the head of the Auckland Fertility Clinic. She has so much of publication to her credit. Here, they published the data of a randomized controlled trial with 201 couples with 3 to 4 years of unexplained fertility. They were randomized to receive 3 cycles of IUI or expectant management. Live birth rate in the IUI arm was 31%, and in 9%, the pregnancy rate happened with expectant management. That was a 3-fold difference in the outcome. Then another paper, which was published in the BMJ Open Journal, the Super Study Protocol by Van Den Hoff. He again did a protocol for randomized control trial comparing FSH and clomiphene citrate for ovarian stimulation in intrauterine insemination. He came out even with another result. He said it was performed in 24 fertility centers in the Netherlands, and including only couples with unexplained infertility, randomized 369 women to IUI with FSH and 369 women to IUI with clomiphene. Results showed that 31% had an ongoing pregnancy following IUI with FSH, and 26% had an ongoing pregnancy following IUI with clomiphene. There was no statistical difference between the two because the numbers were small. So, it came out that it's not only gonadotropin, it is also clomiphene, which is very effective in leading to pregnancies if we start stimulating them with IUI. So having said that, the turning point editorial by editor-in-chief Professor Omelette, he turned the tables in favor of IUI. And what he said was that this was an article published in Facts, Views, Vision, OB-GYN journal in 2017, the same year when this ESHRI conference happened. According to a number of high-quality studies, intrauterine insemination with homologous semen, that means husband semen, should be the first choice treatment in case of unexplained and moderate male factor subfertility. IVF and ICSI are clearly overused in this selected group of infertile couples. So And he also wrote the limited value of IUI in infertility treatment, as mentioned in the 2013 NICE guidelines, was surely a premature statement and should be adapted to the actual literature. So, having said that, again, the same study by Cynthia Farquhar, which I read to you from Auckland, was published in Lancet 2018, where you get all the figures that this was an open label RCT, and they again use the Henol's formula to look into patients who could be put on expectant management and who could go for treatment. So who had a unfavorable prognosis of natural conception, which means less than 30% were taken up for IUI. And they were assigned to 3 cycles of IUI with ovarian stimulation, either with oral clomiphene citrate or letrozole, or with choice of ovarian stimulation. And they were compared to 3 cycles of expectant management. That means couples advised to be sexually active around the likely time of ovulation. Women assigned to IUI had a higher cumulative live birth rate than women assigned to expectant management. You just saw this, 31% vis-a-vis 9% with a p-value of 0.0003. So it was again interpreted that IUI with ovarian stimulation is safe and effective treatment. There was so much more literature which came out. Then this article came out, which had the WHO PICO analysis. And here, William Omelette, who was the editor-in-chief of Facts Vision and Facts, Myth and Vision. He also was into this article production, and they gave us guidelines. I'm just bringing in that guideline where they say clomiphene citrate or tamoxifen are acceptable alternatives to low-dose gonadotropin for low multiple pregnancy and birth rates with lesser cost, although at a lower live birth rate than with gonadotropin. So after having said this, there is so much more evidence-based treatment for couples with unexplained infertility with the ASRM 2020 guideline gave forth to us. One, they said clomiphene citrate with IUI. It is recommended to use clomiphene citrate with IUI in the treatment of couples with unexplained infertility, and the strength of evidence is A. The strength of recommendation is strong. The strong evidence that clomiphene citrate with IUI is superior to expectant management and natural cycle IUI for the outcome of live birth rate. So then we come to the next drug, aromatase inhibitors, letrozole, which is our favorite drug. They again recommended the same thing. And they said there is no significant difference in pregnancy rates or multiple gestation rate following letrozole with IUI as compared to clomiphene with IUI. Both are superior to expectant management and natural cycle IUI. Even of note is there for the Americans, letrozole is not a FDA-approved drug for treatment of unexplained infertility, but is considered an effective and well-tolerated option. Strength of evidence A, strength of recommendation strong. Then again, all the 3 drugs, letrozole, gonadotropin, or clomiphene, for unexplained infertility. And this is not from the American ASRM guideline. This is a trial which was published in New England Journal of Medicine, 2015. And they said in women with unexplained infertility, ovarian stimulation with letrozole resulted in significantly lower frequency of multiple gestation, but also a lower frequency of live birth as compared with gonadotropin, but not as compared with clomiphene. So clomiphene and letrozole were closer to each other, but when it was compared with gonadotropin, the frequency of live birth was lower, but even the frequency of multiple gestation was lower with these oral drugs. Now I come to the most favorite topic of most of my clinicians. They always like to combine clomiphene citrate or letrozole to gonadotropins. They don't want to give gonadotropins alone. A lot of us like combinations. What is a recommendation? It is not recommended to use letrozole or clomiphene citrate plus gonadotropins with IUI, as most studies associated with improved pregnancy rate over ovarian stimulation IUI with oral medication alone are also associated with the increased risk of multiple gestation pregnancy. Though the strength of evidence is B and recommendation is moderate, but this is very important that the moment we add on gonadotropins to letrozole and clomiphene, we will lead to more follicles to grow, and hence we will increase the risk of multiple gestation. So, and I mean, it will give you improved pregnancy rate over ovarian stimulation with oral medication, but the risk of multiple gestation increases. And most of us have seen the wrath of multiple generation, which so many patients of ours fail. So then came the era when we thought we need to compare, when do we shift on to IVF? Do we need to just be satisfied with IUI, or we need to go in for IVF? Now, intrauterine insemination with gonadotropin stimulation or in vitro fertilization for the treatment of unexplained subfertility. This is a randomized controlled trial. And this is very interesting because they took couples with unexplained infertility right from age 23 to 37. 207 couples were randomly assigned to 3 cycles. One where they did ovarian stimulation with recombinant FSH, 101 patients, or 3 cycles of ovarian stimulation with IUI or 1 cycle of IVF. Here, there were 101 patients who went through 1, 2, and 3 cycles, all those who didn't get pregnant, and they went through only 1 cycle of IVF. What was the result? The result was 24.7 singleton live births for the OS IUI group versus 31% for the IVF group. Multiple pregnancy per live birth were 13 in the IUI group, was higher in the IUI group, and 8.3 for the IVF group. Why? Because in IVF, you can always transfer one embryo, whether it is fresh or frozen. Whereas in IUI, if you have given ovarian stimulation and there are 2 dominant follicle, there is a chance that 2 eggs could get fertilized. There was no case of OHSS in the IUI group and 3 cases of OHSS in the IVF group. Now, this is a trial published in Fertility Sterility in 2017. So the singleton live birth with 1 cycle of IVF was not significantly different than 3 cycles of ovarian stimulation and IUI. So if you have unexplained infertility and your patients are less than 37 years and the duration of infertility is not too high, the Henol's prediction model puts them that they're not too bad prognosis patients, then 3 cycles of IUI could be very much a good option, would give you almost 24-25% live birth rate vis-a-vis IVF, which gives you a higher live birth rate, but even the chance of OHSS is more in that, especially in the earlier days where segmentation was less. Now, a randomized clinical trial. Now, this is known as the 40 and over treatment trial, FORT-T. This is very interesting because they took women who were more than 38 years to 42 years and couples with 6 months or more of unexplained infertility. So what did they do? These couples were trying for pregnancy, and because they were of higher age, they reached the clinics faster. And if they already had 6 months of a good trial of expectant management, or they tried to conceive for 6 months, and then they were investigated, found to have unexplained infertility, such couples were taken. 154 couples randomized to receive clomiphene with IUI, that is 51, FSH and IUI, 52 couples, or immediate IVF, 51 couples. The cumulative clinical pregnancy rate per couple after first 2 cycles of CC with IUI or FSH with IUI or immediate IVF were CC with IUI 21.6% pregnancy, FSH IUI 17.3%, which was lower here, 2 cycles, and IVF directly was 49% respectively. There were 36% fewer treatment cycles required to achieve a live birth in IVF arm compared with either of the ovarian stimulation IUI arm. So there was no statistical difference between FSH and clomiphene, even though the percentage was different. but IVF was much faster in giving them pregnancy. So the conclusion was that older women with unexplained infertility, it is to compare treatment initiated with 2 cycles of ovarian stimulation and IUI versus immediate IVF demonstrated superior pregnancy rates with fewer treatment cycles in the immediate IVF group. So what do we get? That if the age is high, don't lose much time in trying IUI cycles. It is best to resort to IVF faster. Whereas in those who are younger, 3 cycles of IUI would give you almost the same pregnancy rate as 1 cycle of IVF. So if the cost of IUI is less, you can go in for that. And here they've only compared recombinant FSH with IVF. They've not used clomiphene citrate in this. So gonadotropin stimulation has been used. But we have seen that clomiphene and letrozole also gives us, but we don't experiment with real patients where we know that time is very crucial for them. Now I'll bring you back to UK again. You saw that in 2013, NICE guidelines abolished IUI. Again, they tried to do the same thing in 2016. And they call this the FAST trial, a randomized clinical trial to evaluate optimal treatment for unexplained infertility, the FAST track, and the standard treatment. They called it the FAST T trial. So couples who were taken, couples with unexplained infertility, aged 21 to 39 years, were randomized for XLO track treatment. 247 women taken with that. There, 3 cycles of clomiphene citrate IUI, 3 cycles of gonadotropin FSH IUI, and then up to 6 cycles of IVF. Or what they did in fast track, they omitted the 3 cycles of FSH IUI. That means they did 3 cycles of clomiphene IUI and then straight away went off to IVF. Now, the results was an increased pregnancy rate was observed in the accelerated arm compared with the conventional arm. Median time to pregnancy was 8 and 11 months in the accelerated and conventional arm. That means accelerated arm took 8 months for a woman to get pregnant and conventional took 11 months. Per cycle pregnancy rate for the CC-IUI, FSH-IUI and IVF were 7.6, 9.8 and 30.7 respectively. But then if there are 3 CC cycles, we would multiply this, and similarly in the 3 gonadotropin cycles, we would multiply the results. Now, look at the reason why they talk about abolishing IUI is average charges per delivery were 9,800 pounds, lower in the accelerated arm compared to conventional treatment. Now, because NHS again has to fund everything, so they tried to remove FSH IUI and bring in IVF, and that showed them that their charges go down. So they said that FSH IUI has no added value, which is right according to them, because they have to fund these FSH IUI cycles, and IUI cycles are damn expensive outside. So when we say IVF, at last, the first after expectant management and ovarian stimulation with IUI, whatever you've used, 3, 4, 5, 6 cycles, looking at what is the probability of her getting pregnant, of the woman getting pregnant, you move into IVF. Or how keen they are to get pregnant, how stressed they are, you decide to move into IVF. There is the summary statement of this ASRM guideline was, there's good evidence that immediate IVF in women more than 38 years of age may be associated with a higher pregnancy rate and shorter time to pregnancy as compared to a strategy consisting of ovarian stimulation with IUI. I need some water. So women who are of a higher age with a may be associated with higher pregnancy rate and shorter time to pregnancy if we do immediate IVF as compared to the strategy consisting of ovarian stimulation with IUI treatment with oral medication or gonadotropins prior to IVF. So high age women, expectant management, move on to IVF. Good evidence that in couples who fail to achieve pregnancy following a course of clomiphene citrate with IUI treatment, immediate IVF results in a shorter time to pregnancy and lower cost to pregnancy than a strategy that incorporates gonadotropin treatment with IUI treatment in women less than 40. Then there is also good evidence that there is no reported difference in clinical pregnancy and live birth rates when we compare IVF with conventional fertilization or with ICSI. So whether we are doing conventional fertilization, that is normal insemination of oocyte with sperms, or we do ICSI in the setting of unexplained infertility. However, ICSI has been associated with higher fertilization rates and a reduced risk of complete fertilization failure as compared to conventional fertilization. So when we do data analysis, we find IVF and ICSI will have the same live birth rate, but for an individual case, there could be fertilization failure sometimes when ICSI has not been resorted to. Having said that, I think now we should all have a good idea about what to do, expectant management, how long to pull through that. Just don't interfere with medicines. If you're giving expectant management, let the patient have natural, good sexual intercourse. I personally feel that to know whether they're having normal sexual intercourse, you do a per speculum examination, and the comfort of a speculum will tell you that they are being able to have proper sexual intercourse or not. In addition, doing a postcoital test further gives me a lot of information whether the couple is able to have proper sexual intercourse. Half the patients are reluctant to have a vaginal examination, per speculum examination, and those are the patients where on postcoital test we find no sperms. They're having inadequate penetration and inadequate sexual intercourse. So very important to identify that group of patients and take them forward faster for an IUI rather than just leaving them on expectant management. So you identify your patients, leave them for expectant management, see that they are strong-willed, they are not already desperate of not being able to be pregnant, then only you leave them. Otherwise, the first line treatment would be ovulation induction with IUI. Depends on your expertise of using gonadotropins. If you don't have it, clomiphene, letrozole, all are now safe alternatives. Even though the pregnancy rates you saw was 7% and 9%, does not matter. Repeated cycle is the key to your success. The best is just give them ovulation induction, look for ovulation, do a IUI, do not use any medicines in the luteal phase, because a untimely given progesterone will stop the woman's chance of getting pregnant. So it is best don't use any additives, just one pure ovulation inducing agent. Follow it up with either LH surge or serum LH levels or ultrasound, whatever you think best. Allow them to have frequent intercourse during that time, and then do a single IUI when you think ovulation is just round the corner. And do not give any medicines after that also, and you will see the best results come out in these patients. If such 3 cycles have not given you results, whether it was oral or gonadotropin, then I think in today's era where IVF is giving us very good pregnancy rates, more than 50% of clinical pregnancy rate and maybe 40-45% of live birth rate, it is best to resort to that. One word of caution, if the woman is of higher age, then maybe we can just do 2 cycles of IUI in case we feel that they've not spent enough time with each other, they've not had adequate sexual contacts, and then move on to IVF or directly move on to IVF. So this is how I would tackle my unexplained infertility cases. Thank you. So now we are open to question answers, and
Ma'am, Dr. Priya is saying that RCOG says that there is no point giving ovulation induction in patients with unexplained infertility.
I would not go for just RCOG, because this Royal College of Obs and Gynae is all governed by UK. The NICE guidelines are governed by UK, and they have their own strategies, which may be different from the world. Even the NICE guidelines in 2013 just said, don't do IUI with or without ovarian stimulation. So I would not really believe something which UK says, where they have to fund every cycle of patients who undergo treatment.
Ma'am, Dr. Sunita wants to know, do we need to do diagnostic laparoscopy to call it
No.
unexplained infertility?
No, no, you need to do a good pelvic examination, a good ultrasound to see whether there are any cyst, adherent ovaries, any masses, whether you can visualize the tubes, then you know that there's something wrong. And if all is good, good HSG, that should be all.
Dr. Shabnam wants to know, ma'am, why to avoid luteal support in IUI?
I'll tell you, I have seen so many people, I have seen so many prescriptions where ovulation induction is used, then Progenova is used, and then Dufaston is used. You do not identify when is she ovulated, and even if she is ovulated, do not load her with progesterone immediately. Let the progesterone rise in the blood. Even for IVF, it is said that in fresh transfers also, do not start progesterone on the day of pickup. Start it 2 days later. So please do not give luteal support. Why do you want to give? You give it if you've made more than 2 follicles, but in that IUI is not permissible. We don't want a more than twin pregnancy to happen, even if it happens. So, I mean, luteal phase is not mandatory if you are using clomiphene or letrozole. If you are using gonadotropin and you've made more than 2 follicles and you still insist on doing IUI, then maybe luteal support with some progesterone would be good. But please make sure the endogenous progesterone has started rising. It has risen for 2 consecutive days. Then only give any luteal support, because a wrong time given luteal support, whether it is Dufaston or vaginal progesterone, both lead to premature luteinization and will stop implantation from happening. Implantation will never happen if you've given a slightly early progesterone. The same what happens in IVF cycles when we give early progesterone, the window closes for implantation.
And ma'am, what is your opinion on the mid-luteal agonist that you give to increase the endogenous progesterone?
See, these are various regimes. The agonist which I give is only to stimulate the LH from the pituitary at a time when HCG is still not forming from the embryo has not formed, or we do not know whether embryo is implanting. And at that time, there are some papers which say that mid-cycle LH surge helps implantation. It doesn't only help the endometrium, it also helps the embryo, the crosstalk, everything. So that is it. But there are still studies which say that our own study did not show any benefit. The one which we did with a long agonist protocol in 2016. But another study which was unpublished, which I did on IUI patients, did show a benefit. So you see, whether you give luteal support with progesterone, you have to ensure that endogenous progesterone has started rising. Only then it is good to give progesterone luteal support, because if you give it early, you would cause the window of implantation to close early. But if you give agonist, like Bhavani, you were asking me, you are not disturbing anything. You're just leading to more LH secretion. And if the theory is really correct that LH surge in the mid-luteal phase helps implantation, it might help. It will not harm the patient. That is my only reason for giving GnRH agonist in the mid-luteal phase, which means day 6, 7, 8.
Ma'am, Dr. Ela wants to know, in the case of only HMG regime, from which day we have to start HMG?
Ila, it is best to start HMG on day 3, because these are normally ovulating patients. If you start it late, already 1 follicle would be selected. Then giving HMG would only have 1 follicle reach the dominant state, that also earlier than it reaches. This follicular phase will become shortened because the FSH levels will go high. So it is best to start on day 3 when follicular selection has not happened and you have a chance that you can recruit 2 follicles to dominance.
Dr. Pratyusha wants to know, do we need to examine the male partner in detail before ordering a semen analysis?
You
Or
tell
we can
us,
directly
Bhavani.
go for...
Tell us.
Ma'am, I think we can directly go for semen analysis. If that shows an abnormality, then we can examine.
It is important to examine only after. So, uh, unfortunately or fortunately, infertility clinics are mainly female gynecologists dominated. And in my era, we hardly examined the males, but now the era has changed. All my juniors, as well as the next generation also, are all examining the males. But the first and only examination for the male which we order is a semen analysis. And if we know that this is this man's semen and there's been no hodgepodge in that, if the semen analysis is normal, we don't need to examine the male. We only need to see whether they are having proper sexual intercourse or there is any history of erectile or ejaculatory dysfunction.
Ma'am, another question which has come is that in gonadotropin IUI cycle, do you prefer to give low dose gonadotropin daily or on alternate days?
You tell what is my practice. We
Ma'am,
always
you give it daily. Daily.
yeah. You have to find a dose which will not lead to hyperstimulation and which will not even stagger the cycle. So you use a small dose on a daily basis and again start on day 3 because these are normally ovulating patients. If you start later, you may start on day 4, but day 5 is always too late.
Dr. Shivani is asking, please suggest what a general gynecologist can do for unexplained infertility as induction protocol.
Very nice question, Shivani. I think you missed the initial part. You first see the couple, see if the girl is young. They are married for, they are trying for pregnancy for just about a year or two. The semen is normal. The coital practices are normal. She is ovulating. You have to ensure that she is ovulating by doing a serum progesterone, ultrasound, whatever you want. And once you see all this is okay, and there are no coital difficulties, she allows you examination also easily and the couple says that they have no difficulty, you can leave them for expectant management for 1 more year or maybe 2 more years. But if they are already stressed, then the next line of treatment is ovarian stimulation with IUI. As a general gynecologist, you would be safest in a woman who's menstruating regularly to give clomiphene or letrozole. Clomiphene because it leads to more multifollicular development. If she's not a hyper-responder, she will make 2 follicles. Letrozole also could make 2 dominant follicles, but mostly would make 1 dominant follicle. In patients with unexplained infertility who are ovulating regularly, maybe it can make even 2 dominant follicles.
Dr. Priya wants to know, can we give letrozole and HMG
I
together
just
for
showed you such a
IUI?
great paper about this. Let me see if I can get back to that paper.
The ASRM recommendation which said that there is no role
There's no,
because of increased multiple pregnancy.
yeah, I'll just show you this. I mainly brought in because of this combination of clomiphene citrate or letrozole and gonadotropin with IUI. It is not recommended to use letrozole or clomiphene citrate plus gonadotropin with IUI, as most studies associated with improved pregnancy rates over ovarian stimulation with IUI with oral medications are also associated with increased risk of multiple gestation pregnancy. That is important. So if you add gonadotropin with clomiphene letrozole, so you will definitely cause multiple follicles to grow to dominance, and then the risk of multiple gestation increases. And you have to ask us how many complications we see. One normally delivered twin pregnancy would have 2 to 3 twin pregnancies which are lost in the way somewhere. So it is always better not to put the woman into the risk of multiple gestation.
Dr. Shalini wants to know, is there any role of double IUI?
Well, Shalini, double IUI is if you feel that you've missed the train in the first one, ovulation did not happen, or you are doing AID where natural intercourse will not expose the woman to any type of sperm, then maybe double IUI may have a role if you've missed out on the LH surge on ovulation. Otherwise, all evidence says that single IUI should be good enough for a woman to conceive.
Dr. Nikita is asking if progesterone is
Very
started
interesting
after
question.
2 days of OPU, then is day 3
So
embryo transferred on second dose.
what I do in my practice on the day of OPU, we don't give any progesterone. Next day night, progesterone is started. Is that the normal practice if we are doing a fresh transfer? What is
Yes, ma'am.
this is the
Next
normal
day
practice.
evening,
Next
next
day
day
evening
evening.
we start. So OPU is done in the morning, and that day no progesterone. Next day evening we start progesterone, and if you do a day 3 transfer, you do it on that progesterone. It is not the exogenous progesterone we are really banking. Endogenous progesterone is being produced after OPU. So please understand that if you are transferring a day 3 embryo, you are not doing it on the second dose of progesterone. If you are giving a BD dose of progesterone, then you've given it the night, and then next day morning, night, and then you transfer. And it is not on this progesterone that the implantation will happen. Implantation will not happen on day 3. When you put in a day 3 embryo, it keeps rolling into the endometrial cavity till it becomes a blastocyst, and then it hatches, and then it implants. So progesterone exposure has to be 5 days. The window of implantation will open only after 5 days, or maybe a little later, and then only the embryo can implant. So a day 3 embryo doesn't go and just catch on the endometrium in 2 days. The window of implantation is not open, Nikita. So please don't worry about this.
Someone has asked, if we use 37.5 units gonadotropin, then do you discard the remaining dose in the vial, or you can
Use
store it?
multi-dose vials. Whenever you have to use small doses, use multi-dose vials. For HMG also, multi-dose vials are available, and for recombinant gonadotropin also, multi-dose vials, pens, all are available. So don't throw the dose at all. It is very expensive.
Dr. Pujita wants to know how many maximum cycles of OI/IUI we can do before suggesting IVF, 3 or 4.
Now, Pujita, you tell me, if a woman is 32 years old, how many would you want to do? And if she's 40 years old, how many would you want to do? I think someone can answer out of, or maybe my coordinator can answer this. How many would you want to do if the patient has come with unexplained infertility of 3 years duration? She's 32 years. And how many would you do if she's of 39 years and has come with 2 years of unexplained infertility?
In a 32-year-old man, we can do 3 cycles, but in an advanced stage, 39, maybe up to just 2 cycles.
Correct. So, Pujita, this is the answer for this, that in an advanced stage, you do not use a lot of chance with IUIs, whether it is oral or gonadotropin. But in a younger woman, you can take up 3 cycles of either oral drug with IUI or gonadotropin with IUI. And you can go up to 4, 5, 6 cycles also, like in the slow track UK model, where first 3 were done with clomiphene, second 3 with FSH. And there could be a cumulative pregnancy, which may not be too bad if you do not have access to IVF or the patient is not ready for IVF.
Dr. Shalini is asked.
Tubal patency is a must prior to IUI. Ideally, even in a PCOS patient, if you want to resort to IUI, you must do a tubal patency.
Dr. Ayushi is asking, if there's no folliculogenesis with oral ovulogens, then should we add gonadotropins and try IUI, or directly go for
We are not
IVF?
talking about patients with PCOS or hypo Ayushi. We are talking of women with unexplained infertility who are ovulating regularly or ovulating with ovulogens. If there is underlying PCOS also, and you give them any oral ovulogen, they are ovulating. Then they are taken for IUI. They are not taken for IUI when we are experimenting with drugs to see do they ovulate or not. So they have to ovulate. But if they are not ovulating, then the treatment is not IUI. It is just to induce ovulation and let them try natural intercourse if the semen is normal and there's no sexual dysfunction.
Dr. Nitika is asking, if we use dual trigger in fresh transfer, when to start progesterone?
Same, 48 around next day night. We just told you, no, that the day of oocyte pickup, we don't start. Next day by evening, we start the first progesterone dose, and because we use in a twice a day doses, so morning, night, they will continue in the whole luteal phase. Okay. Any more questions? Did you learn anything from this class? I want my audience to write in the chat box. Has anything become clearer to you after the talk? Because that is
Uh,
what I
Ma'am,
want to happen.
excuse me, ma'am.
Yes.
Ma'am, I raised one question. Actually, someone interrupted me. I just want to know if we are doing the fresh transfer and we have given the dual trigger, then also we should start the progesterone on the day 3.
See, if you're doing a fresh transfer, when you've stimulated a woman with either agonist or antagonist protocol, you will have to give progesterone. But all the text says that do not start progesterone immediately after ovarian stimulation because natural progesterone is being produced. And sometimes you'll be surprised on the day of oocyte pickup. If you do a serum progesterone, you will find it as high as 12, 13, 8, 9, 10 also. And it was a study of one of my juniors. Parul did this study, and she found a cutoff of 11, where she said if it was less than that, it was okay. If it was higher, pregnancies did not happen because the window of implantation was dysynchronous. So if you give a dual trigger in a fresh transfer also, in a stimulated cycle, progesterone starts being produced immediately. So do not hype up the progesterone immediately on the day of oocyte retrieval. You can start adding progesterone next day by evening to supplement the progesterone which the body is already making, Nikita. All right?
Okay, ma'am. Ma'am, should we give estradiol also in a low
No.
dose dual trigger?
No. See, we used to give estradiol once upon a time, especially in the long agonist protocol, where we were bound to do a transfer even in cycles which were hyperstimulated. Now that era has gone. If your cycle is already hyperstimulated, it is better not to do a transfer in that cycle. Reserve your embryos for a FET. Because if you give in a very high E2 cycle, if you do a fresh transfer, and the estradiol levels generally fall in the luteal phase, we do not know it as a cause or effect. If failing implantation is happening, then also estradiol could fall, or maybe by the earlier theory which we used, what you're saying, low dose progenova to support the luteal phase. That was a very old theory that has long been lost now. We are moving ahead. We do not do transfers in cycles where E2 levels are more than 1500 or 2000 and we've recovered more than 14, 15 oocytes. So it is best to refrain from transfer in the same cycle. Don't do a fresh transfer, Nikita.
Okay, ma'am. Thank you, ma'am.
Ma'am, there's also practice amongst many clinicians that even in younger patients with low reserve, they tend to resort directly to IVF, ma'am. So what is your opinion on that?
Yeah, younger patients with low reserve. See, again, I have identified that a lot of patients who come to us are not having enough sexual intercourse. If they are not having enough sexual intercourse, maybe IUI is a good option for these couples, where either the woman has vaginismus or the husband has erectile function. So many couples who come do not allow you a per speculum examination, do not allow you a PV, and if you do a postcoital test, you never find sperms inside them. So I think low reserve, having good sexual contact, having been together for 2 or 3 years, straight IVF is a good option. But if they are not having proper sexual contacts, then 2, 3 cycles of IUI will not lose her ovarian reserve so fast. A young patient. What do you say? What is your opinion? Give me your opinion also. I want everyone's opinion.
Yes, ma'am. I also feel that if there's a short duration of infertility, patient is young, and even if she has low reserve, we can counsel the patient and
Yeah, we
go
don't
for
leave her
2
so
or
much
3
for,
cycles for her.
yeah, we don't leave her with expectant management so
Not
much.
expectant, yes, but
Yeah,
IUI 2, 3 cycles we can.
3 cycles definitely I would
Yes.
want to give. And I always tell them reserve doesn't drop over months, it drops over years. So don't be panicky and don't run that, IVF is the only resort right now. So
Yes, ma'am. I'm Shalini. I would also agree that IUI works good in younger patients.
yeah, good. I'm glad you are there. So
Yes,
I,
ma'am. I
I hope
missed.
I hope we all must have a take-home message. And for me, the take-home message today was that I read this whole chapter And I never used to use letrozole, but my take home is that I could also use letrozole, and I would want to see whether there is a multifollicular response in them or not. And someone who asked that if we combine letrozole with gonadotropin, I feel that if letrozole is causing a monofollicular response, then combining gonadotropin is not a bad idea, because if you say what they've written is that it is only they have had an improved pregnancy rate over ovarian stimulation IUI with oral medication when they add gonadotropins, but they also have increased risk of multiple gestation. So I would want to use it, gonadotropin with letrozole, only in a case where I think I can lead to follicular growth. But the agony is that if you've used letrozole and you call them on day 10 or 11 for ultrasound, already the dominant follicle has grown, and giving gonadotropin then will not lead to a multifollicular response. It is only in the next cycle where you can use letrozole and maybe combine gonadotropin on the last day of letrozole to lead to 2 follicles to grow. Maybe. Try and see. I'll try and see. Right, Bhavani, do you think this is correct, what I'm saying?
Yes, ma'am.
That only if there's a monofollicular response in the first cycle, adding a small dose of gonadotropin in the next cycle, but early, will help to select 2 follicles. नहीं आए वो लोग? आ
Ma'am,
गए।
may I add something to this?
Yeah, बोलो।
Shalini.
बस,
Yeah.
हाँ,
I normally at times, even in letrozole cycle, I call them on day 7 and 8 of the cycle. So if there is already follicle which has taken the lead, say maybe 12 or 13
then it's no
millimeter,
need
and
to add.
yeah, then there is no need. But if there
हाँ,
are like say 2 follicles
correct.
which are say 10 millimeters, then probably
Then you
adding a
can.
little gonadotropins, it really helps in
So,
giving 2
yeah,
follicles,
this
ma'am.
is a good policy to do this, I think.
Yeah, so I normally call my patients on day 8 and then take the decision accordingly.
All right. So I think we've had very good discussion today. And thank you everybody for joining me. I have an urgent requirement, so I'm leaving fast. There are
Sure,
some
ma'am.
people who are waiting for me. Thank you, Intas. Thank you,
Thank you,
Vivek
ma'am.
Sharma, for helping us, Bhavani, and all of you who make this class worthwhile. I'll continue to take this class as long as everyone wishes to. And whenever you get fed up, just say, ma'am, stop taking the classes, and I'll also.
That will never happen, ma'am.
Okay,
I
thank you so
missed quite a initial of your talk, but whatever I could attend, it's
It
always
will be
worthwhile.
on the website, so you'll be able to hear it again.
Sure, ma'am.
It goes on the website.
Yeah.
And
Ma'am, just one
class,
small question.
huh,
In elderly patient, I mean, like say 35, 36, you prefer clomiphene or letrozole? I mean, obviously,
I give
uh,
gonadotropins and all because I'm quite okay with gonadotropins. But if you have less expertise, you can use either of the 2 drugs.
yes, ma'am.
Tejasvi, any comment you would want to make?
So
Ma'am?
I think with elderly patients, we always prefer gonadotropins better. If to be made a choice between letrozole and clomiphene, I would prefer clomiphene. Just a
Yeah,
personal choice, no evidence for that.
yeah. All right, so we can leave now, I think. Thank
Yes,
you.
ma'am.
Thank you
Thanks
so
for
much,
coming.
ma'am,
Thank
as
you.
always, for
Thank
all
you
the
so much.
efforts.
Thank you.
Yeah,
I
thank
see
you,
so
ma'am.
closely
Bye-bye.
about how
Thank
you
you,
take
ma'am.
so much effort to make the presentations always. Thank you.
Yeah,
Yeah. Bye,
yeah.
ma'am.
Thank you.
Thank
Bye,
you,
ma'am.
ma'am.
Okay, ma'am.